We are recording. I am very, very happy to introduce Dr. Wall, who is a pediatric emergency specialist physician, and I'll let her explain and tell you all about what she does. But I met Jesse down at NAMSP in Austin, and how we met was that there was a group of us in the exhibit hall, but all of us were from Washington State. And then all of a sudden we started talking. I heard what Jesse does. I said, "Oh, well, how about coming and talking to our EMTs and paramedics that at our BLS focus training?" And not a hesitation from her, not at one bit. She said, "Sure, absolutely." So with no more delay for me, Dr. Wall, welcome to our BLS focus training.
Cool. Thank you. All right. So Steve kind of alluded to it. I'm a little odd. I have a lot of jobs. I'm very ADHD that way. I'm a total ER doctor. So I actually started in EMS as an EMT 20 something. We're just not going to go beyond 20 years ago. And then worked as a paramedic for a while, and then became an ER doctor, and then did additional training in pediatrics. So I do bizarre many things, but one of my passions in the world is how do we take care of kids in the pre-hospital setting, because literally some of the pediatric cases that I had as an EMT and a paramedic are what really stuck with me and quite frankly terrified me and pushed me into my career in pediatric emergency medicine. So this is why I kind of like going back to the basics. So we are going to talk about demystifying the pediatric assessment triangle. Let me see if I can get my stuff here. I have lots of jokes because I think lectures are boring. So please tolerate many of the memes that I have. It's how I try to make people smile. And I am going to warn you, you don't have to be on camera. I fully get it, 7 o'clock at night, and it's not the best time to be on camera. But if you would like to put answers in the chat, there are some questions and some interactive parts to this. So I would appreciate it if you do that. Otherwise, I'm just going to lecture to you for a while, and that might get a little boring. So the pediatric assessment triangle, we're going to go through kind of piece by piece the appearance, breathing, circulation of it, which we talk about the pediatric assessment triangle a lot, but I don't think we break it down really well into the inherent pieces and what it actually means when we use it to assess a patient. So we're going to kind of demystify it. We're going to figure out how it's actually helpful to us in the pre-hospital setting. So interestingly, the pediatric assessment triangle was not developed in the pre-hospital setting. It was developed in the hospital setting and extrapolated to the pre-hospital and then back and forth somewhat. It's designed as a rapid visual assessment for pediatric patients. It can be done from the doorway or across the room. It is literally that I take a quick look at you and I decide you're sick or not sick. Interestingly, in doing this, it predicts sick in a child about 80% of the time, meaning it's 80% sensitive. So you look at a child, you decide that you think they're sick or not sick. 80% of the time, you are going to be right when you say they're sick. That does mean that there is a 20% that you could be missing with the pediatric assessment triangle, which is why we go into our primary and secondary survey. And we'll talk about that a little bit more. So let's start with appearance. How should kids appear? I really think of appearance as it's like the neurologic assessment. It is the quick down and dirty. Are you actually getting enough oxygen, glucose, blood to your brain that your brain is functioning in a way it should be at an age appropriate level? That's kind of that down and dirty quick check of how's the brain doing. So when we think about appearance, we like to break it down into tickles, which gets complicated, but it's not that bad. So tone, interactivity, consolability, look, gaze, and speech and crying. So in kids, what does that mean? So all of this is on a spectrum of age. Everything is developmentally and age appropriate. But when you think about tone in a pediatric patient, are they moving spontaneously? Are they holding their head up? Are they sitting or standing? A brand new baby or a baby in the first couple of months of life actually kind of curls up. They like to have more tone. They curl into themselves in a little more centrally tonic in that sense. They tend to not be sort of floppy and flaccid. They don't have their arms way out. They, in general, are sort of more curled in sort of what we describe as the fetal position. That actually is a position. And that is what most of them are in. So when you look at patient's tone, you want to look at, is this an age appropriate tone? A 2-year-old should be able to sit up or stand up without a problem. A 3-month-old or 6-month-old should be able to hold their head up without a problem. So thinking about, does this fit with what I expect for this patient? Now, truth be told, There is an entire fellowship in developmental milestones. I have not done it. Many people have not. But think about either your own children or the kids that you have seen as they grow up, nieces, nephews, cousins. And so think about, hey, okay, so, my niece at 3 months old was doing this. Those are actually relatively appropriate developmental milestones. And that's how you should think about these things. Interactivity. So are they alert? Are they interactive with the caregiver? Stranger danger, super real thing. They may not want to interact with you. They may not like you a whole lot, but they should be interacting with their caregiver if they're present. Are they reacting to the environment? So do they, most really little kids, until they kind of get that stranger danger and sort of the 2-year-old range, most of them will want to play with you. As they get older, they'll get more scared of you. And that's also an appropriate reaction to their environment. And most importantly, are they aware of you? Are they tracking you? Then consolability. If they're crying, if they're fussy, can they be consoled by a parent? Can they be consoled by a toy? Can they be consoled by an iPhone or an iPad? Some of my favorite tricks in the world to figure out, is this kid actually like just flipping out and I have a problem? Or is this kid flipping out because I'm scary and I need to calm them down? Is I give them a toy. If they calm themselves with a toy and they're like, hey, cool, you gave me bubble stuff. Hey, cool, you gave me an iPhone, then that's a consolable child and that's reassuring. Now, if they're just continuously crying, they will not stop, completely unconsolable, then that's actually kind of concerning to me, that there may be something underlying and it's not just anxiety. Look and gaze. So are they looking at you? Do they make eye contact with you? They should be able to make eye contact 6 months and above. 3 months, they should actually be able to track without a problem. And less than 3 months, they actually should track across the midline, but they may not make good eye contact tracking you the entire way. Do they track movements in the room? And then importantly, when you're thinking about pediatric look and gaze, they should always be able to track across the midline. This is kind of a duh statement. We think about older kids and adults is you'll distract them one way, they look one way, you distract them the other, they look the other, or you have them follow your fingers. A little baby may not follow your fingers, but you should be able to give enough stimulation that they'll look both directions. And that's important as part of a mental assessment. And then speech and cry. Are they using age-appropriate speech? So I don't have my children of my own, but I have a niece. She's 2 years old, and I expect a certain vocabulary out of her. She's not going to hold a full conversation with me, but she babbles some things, and some things she has words in, and that's appropriate for a 2-year-old. And then also, are they crying normally, or does the family say, this is a weird sound? Because a weird sound coming from a child, the family knows what their cry should sound like, and that should help tip you off. Maybe there's something up here. So when you think about appearance, overall, you want normal tone, you want movement in all extremities, their eyes need to be open, and they should be able to track. Anyone over 6 months old should at least respond to their name. They should at least turn their head to track you. And they should have normal speech or cry, again, age appropriate. Abnormal things, we like to hang our hat on anxiety a lot in pediatrics. And what I teach all of my crews that I work with, both paramedics and EMTs in King County, Airlift Northwest flight nurses, and then the EMT and paramedic programs that I teach at for primary education, is that anxiety is a diagnosis of exclusion. You cannot say it's anxiety until you've ruled everything else out, because you're likely to miss something if you want to hang your hat on, it's just anxiety, they're just scared of me, it's not a big deal. So in general, I consider agitation or anxiety abnormal in a child until I have spent some good quality time with that kid and decided, okay, maybe this is just they're terrified of me, they're a really anxious kid. But again, that takes time. That's not a quick pediatric assessment triangle thought process. I've spent a good 20 minutes with you and worked this out. Other things that are abnormal, of course, decreased responsiveness, limp or listless, floppy, or also rigid body tone. So while they should curl up a little bit, they should actually have good movement everywhere. So a limb that's staying rigid is concerning to me for pathology. Inconsolable crying, failure to recognize their caregiver or to track their caregiver, or then failure to respond to the environment, especially painful stimuli or just stimuli in general, should concern you that there's something going on within sort of the brain. Who knows what yet, but this is, again, your door assessment, but something is amiss. Now, let's talk about breathing. So second aspect of our triangle. When we think about breathing, really our purpose is to assess what it looks like and what it doesn't sound like. So when I say what it looks like, I'm looking at, is the airway adequate? Are they moving good air, or are they retracting a lot? Does it look like they have good chest rise? Do they have good ventilation? So again, good chest rise without a lot of retractions and is an appropriate respiratory rate. Oxygenation is a little harder depending on skin tone, but do they have what I would perceive as normal skin color in this patient? And then what it doesn't sound like. Pediatric patients, just like you and me, when we're breathing, standing up, doing nothing, your breathing is actually pretty quiet. And that's true in pediatric patients too. If you're hearing snoring respirations, if you're hearing stridor or gurgling, something's wrong. That's a concerning pathology. When I look at breathing and break that down even further, and note, we're not using a stethoscope yet. This is me looking at a patient from the door. I'm looking at their body position. So we talk about tripod position a lot in adults. Kids don't really do a true tripod position. They'll do sniffing position. Sometimes you'll see, especially a child with a really bad croup, they'll straighten their neck out and they're trying to actually make their airway a little bit more sort of laminar flow to compensate for the obstruction that they're having with inflammation from croup. The other thing you'll see in pediatrics is they'll sit in a seated position and they'll sit bolt upright. Bolt upright is the pediatric equivalent of tripod position. It means they are trying to hold a good body position to assist ventilation because they're working hard to breathe. When you look at respiratory rate, it's important, and I'm going to tell you this, total confession, I was an EMT for about 5 years. Yeah, like everybody had a respiratory rate of somewhere between 16 and 20. That is literally the number that I wrote down in my chart always, and I'm embarrassed to say it right now. In pediatrics, please don't do that. Count it in kids, because the respiratory rate is a really sensitive indicator for if they're having a respiratory problem. Interestingly, the respiratory rate is actually a really good indicator of shock. Tachypnea in a pediatric patient is the first sign of both a respiratory problem and shock. So you really, really want to count it and you want to compare it to your norms. Other things to look for are bradypnea. If you clock a 2-year-old breathing at 14 times a minute, I'm terrified because that's way too low of a ventilatory rate for that age. And so making sure that you're actually counting the rate and that you're comparing it to whatever reference you have for pediatric norms. And we'll talk about that a little bit more as we get through this talk. Respiratory effort, retractions. I have some videos at the end, but it's really important to take a look at their skin. Do you see retractions? So suprasternal retractions, you get this tracheal tug, we call it. Supraclavicular retractions, so do you see skin tugging by the clavicle? Intrathoracic retractions, so you'll see retractions in the ribs with skin between the ribs, or you'll see retractions underneath the rib cage at the very bottom, at the costophrenic margin. All of those are indicative of increased work of breathing. Kids can look really good when they're actually working pretty hard, and subtle things you're going to catch are their respiratory rate's a little faster and they're retracting a little bit. Other things to look for are belly breathing. So kids will naturally breathe a little bit with their belly, but they shouldn't be breathing a lot with their belly. There shouldn't be a big movement in the abdomen. Maybe a little bit's okay, a lot really not okay. And then head bobbing. As pediatric patients get worse and worse with their respiratory effort, as they have more and more difficulty, you'll see their heads will actually bob with their respiratory effort. It's part of them trying to increase and decrease their thoracic resistance as they try to pull air in and let it go back out. So it's an important thing to look at. Other things for abnormal airway sounds. Any airway sound is abnormal in a pediatric patient. So grunting, gurgling, snoring, wheezing, and stridor. I'm going to talk about those. So when you're listening for sounds, so grunting, gurgling, snoring, stridor, and wheezing. So what is all this? Grunting is the sound that terrifies me. I have literally admitted small children to the hospital because they were grunting and I didn't know why, and there's no way I was going to let them go home. Grunting is the short, low-pitched sound at the end of exhalation. It's sort of a It's actually a sound that they're making to generate PEEP. They're trying to generate back pressure. So, and it's actually, they're exhaling against a closed glottis. They're trying to force their lungs open a little bit. It is a sound that you find in patients that either have obstructive pathology in their lungs or something else that's causing a lot of dead space ventilation. So a child that's grunting, that is a sick child until proven otherwise. Gurgling, this is sort of a duh statement. It's fluid that's collected in the upper airway. Normally, every child, even a brand new baby, should be able to manage their secretions. So if they're not managing their secretions and it's causing gurgling as they breathe, that's a problem. Something's going on with their ventilatory status or their mental status. Snoring, same thing, narrowing of your upper airway. This is not a normal sound. Now, granted, if they're sleeping peacefully and they're just the most adorable toddler and they're snoring and they're totally fine, and you wake them up and the snoring goes away, that's probably okay. But a child that's snoring in front of you and is not clearing that appropriately when they wake up, that is an abnormal breathing sound. Stridor is this sort of high-pitched, harsh sound that we hear on inspiration. We think of it associated with an upper airway obstruction. So most commonly, that would be croup. Next thing would be that we think about would be a foreign body. Now, wheezing is a little challenging compared to stridor because stridor is basically a wheeze of the upper airway. Stridor is what we call monophonic, meaning it's one sound. It's maybe a loud sound, but it's one sound. Wheezing is a high-pitched sound heard on inspiration and exhalation, and it's in the lower lungs. And wheezing is what we call polyphonic. So stridor is one sound that sounds like a wheeze, but it's only one sound. Wheezing itself is actually multiple sounds of wheezing all at the same time. And that's how you can differentiate between stridor and wheezing if you're trying to listen for it. Once you do get past your pediatric assessment triangle and you grab a stethoscope, putting the stethoscope on the throat and then putting it on the lungs will help determine stridor, which should be up here mostly, and polyphonic wheezing, which should be in the lungs. So breathing, normals and abnormals. So normal should be quiet, should be easy chest rise and fall, very comfortable. There shouldn't be no retractions, no work going into it. They should have a normal age appropriate respiratory rate, and they shouldn't be using a lot of accessory muscles. There shouldn't be any head bobbing, any other movements to try to help them breathe. Abnormal is abnormal position, that kid that is sitting bolt upright that has some sniffing position going on. So they're extending, trying to account for what they're having difficulty with. Abnormal movements with breathing. So again, retractions, head bobbing. Nasal flaring I didn't mention, but nasal flaring is interesting. It's actually inherent to breathing. We will see children nasal flare even when they're intubated because they're working to breathe against the vent. And so nasal flaring is an indication of increased respiratory effort. It is a physiologic phenomenon that your body does when it's trying to work harder to breathe, just like head bobbing. Retractions, and then any audible sound. That's not normal. You got to have an explanation for it. And then abnormal respiratory rate for age, of course. All right. So when we talk about respiratory rates, and we're going to talk about peds vitals several times in this lecture, remembering your pediatric norms. So I'm going to tell you, I've been doing pediatrics for almost a decade now. And I could not tell you, if you give me the weight and or age of a child, I could not tell you the exact cutoffs of what their heart rate should be or what their respiratory rate should be. I'm just not that good. Use a resource. Have a resource, whether it is in King County, we use the moped cards, Airlift Northwest, we call them the pedal cards, but use, whether it's an app on your phone, you use Hand Heavy, use Check the Dose, whatever you use, have a resource to tell you what the norms are for that age. It's really important to not try to do it from memory because even the smartest of us can't do it. Hand Heavy is great. Does your BLS use Hand Heavy too? Perfect.
They can. They have options to have it on their phone, and
Awesome.
I think most of the put it on the rig phone. I don't know how many people have it on their personal, but we definitely have enough.
Perfect. That
License.
accounts, yeah. And I would tell you, quite frankly, if there are enough licenses that you could get Hand Heavy on your personal phone, put it on your personal phone. This is the pediatric vital signs cutoff that we've made for BLS within our county right now, because King County is not currently app-based. And this is same concept, is you should be able to identify the age of the patient. If you have a weight, you can use that too. Either one, we gave both the option, and then have your normal vital signs there because none of us remember normal vital signs. All right, circulation. So this is really assessing for perfusion, which is sort of like assessing for cardiac output, sort of the poor man's cardiac output. And so you really want to look at skin color. Is it normal for the patient? Oops, sorry, I didn't mean to click that too quickly. Now, the challenge with circulation is it's a little hard depending on the patient's natural skin tone. And so it can be a little subtle, and sometimes you can be misled and you need to rethink it once you get vital signs on the patient. But this one's pretty basic. Normal skin appears normal color. And I often will ask, how does your child look to you? I've had patients that I've looked at that have been like, that is a very pasty looking kid. But mom and dad are like, oh yeah, this kid's always this color. Or I've had kids that have had sort of like a jaundice color to them. And I was like, is this normal? And they'll be like, yes or no. But I use parents as a reference. They look at their child every day and they do a good comparison. So you can ask them really any abnormal color. So pale, mottling. If the kid is flushed, it can indicate fever and infection. Cyanotic is sort of a duh statement as bad. We never like blue or gray kids. And then again, ask the family member. All right. So what happens if 1 or 2 or 3 of your pediatric assessment triangle size is abnormal? By definition, that child is sick. If your doorway assessment looks at the child and either appearance, breathing, or circulation from your doorway assessment is abnormal, that child is sick until proven otherwise. Now your job is to do a more thorough assessment, start intervening, and work your way towards getting that child to a hospital. So if you want a really technical breakdown of the different ways this can be assessed, so the stable kid, your appearance, your breathing, your circulation looks good, 80% of the time, that kid's 100% fine. 20% of the time, you got to do a little more investigating because they might be sick hiding underneath the surface. But what happens if you have breathing knocked out? Circulation is good, appearance is good, but they're increasing work of breathing. That is respiratory distress by definition. Respiratory failure is now work of breathing plus appearance, meaning their work of breathing has gotten so bad, it's affecting their mentation. And that is respiratory failure. You might be able to rescue them with some oxygen. You might have to rescue them with a bag valve mask. You may have some interventions to do here, but again, 2 things out, that's respiratory failure. Shock is a little tricky. Shock is, by definition, circulation is out, but it depends on if they've compensated or not. Compensated shock, they might actually still have normal mentation. Their appearance might be okay. But as they decompensate and they work their way further into shock, now they're going to have mentation problems, since you may have abnormal mental status too. Central nervous system problem, examples of this would be seizure. Another one would be a child that has a VP shunt in place that's malfunctioning. This is a child that has an appearance problem. So a mentation problem, but breathing and circulation are okay. And then cardiopulmonary failure, all 3 are abnormal. And now you have some catching up to do and some work to do. And you really want to get that kid to a hospital sooner than later. All right, so still a mystery, we're going to do some examples. All right, case 1. And we're going to do examples in a couple of ways today. We're going to do just pediatric assessment triangle examples, and then we're going to do some videos at the end. And thank you for smiling at my joke, Steve. I appreciate it. All right, I know. I was like, you know, if you're my age, you actually do remember Columbo, at least the reruns. Okay, so 8-month-old with fever. Your doorway assessment. Patient is held by parents, so mom's holding the 8-month-old. The eyes are closed, and the kid looks kind of like they're sleeping in mom's arms. They're not holding their head up. They're kind of laying their head on mom's shoulder. Extremities are sort of falling down at mom's side, so not really doing anything. She's breathing a little fast by your count. We'll say her rate's maybe around 60. You see some intercostal and subcostal retractions, some head bobbing, and she's a little pale. All right, so you have now, we're going to break it out. So your appearance, your breathing, and your circulation. What is wrong here? Appearance, breathing, or circulation? This is the interactive portion, guys. Just to warn you, I will wait a full 10 seconds until you put an answer in, or else I'll just move on. All 3. Thank you, Adrian. You're my hero today for putting an answer in. All right, so this child, I would argue too, I agree. All 3. And appearance and breathing, definitely. All right, so Christian, yes, I read that right. All right, so all 3. So this child is pale, this child has increased work of breathing, and their mental status is poop. So this kid is sick by definition. Thank you all very much. And thanks for playing. All right, so how about our next kiddo? Oh, come on, I loved House. All right, so this is a 2-year-old male with cough and runny nose. When you walk in the house, he is sitting on mom or dad's lap. His eyes are open. He's looking around. He's calm. He's not freaking out. He is holding himself up. Maybe mom or dad has a hand on their back, but he's holding himself up, looking at you. He's a little tachypnic. He's breathing a little faster than he should. Maybe his respiratory rate's around 40, 45. He's got some intercostal retractions. He's got some stridor. You hear this sound, this kind of barky sound, and this weird sort of sound when he takes a deep breath in and deep breath out. He keeps coughing, and you hear this barky cough. and his skin color is normal. So again, that in a nutshell is our pediatric assessment triangle. So has he knocked anything out of the pediatric assessment triangle here? Breathing. Yep, it's breathing. Absolutely. So this kid is by definition also sick. He's only taken out one arm of the pediatric assessment triangle, but again, by definition, he is sick. And he's going to need some therapies and some interventions. It's fun for me because croup, we can fix that, man. There's great nebs, some steroids, and I can make it better. But he definitely needs some things to improve. Okay, so next case. So this kid, this is a 9-year-old who's not feeling well, is the call you get. When you walk in, he is laying in bed and he's propped up by pillows. His eyes are open, but he's kind of staring off and he doesn't really track you. He's not moving spontaneously. He's kind of just sort of a limp noodle. He's not really reacting to activity in the room. A whole engine company comes in and he's kind of not responding to the fact that a whole bunch of big human beings just strode in. His respiratory rate is 12. He has no work of breathing and he has no audible lung sounds. And his skin color is normal. What's wrong with this child? Which limbs are out here? Appearance and breathing. Thanks, Jeff. P.S. Jeff, I saw Commissioner earlier and I just wanted to be like, oh, it's the commish. Anyway, sorry. Old references. All right. So this is sick or not sick too, and this kid is definitely sick. Appearance and breathing for sure. His skin color is fine right now, but I got to tell you, with the mentation he has and the fact that he's not breathing fast enough for a 9-year-old, this to me is like, oh, we got some problems. We have some things to fix quite soon, and I'm worried about this kid. So absolutely 100% sick. All right, so you assessed the pediatric triangle. Good job. You came in. Now what? You look, I mean, we've basically just gotten from the I'm standing at the door looking at the kid. You actually haven't even touched the child yet. So it's really important to remember the primary survey can start with the elements of the pediatric assessment triangle. The primary survey is like your pediatric assessment triangle is sort of like the preamble to your primary survey. But what's really important, and it's important, is when you get your pediatric assessment triangle, it can guide interventions as you do the primary survey. So any child that's really sick as you walk in, as you're starting your primary assessment, your primary assessment, now is a good time to be like, okay, we might want to do some oxygen. We might want to get some things out. We might want to call for ALS, depending on what system we're in. We are probably going to be moving towards the hospital no matter what. It kind of starts informing your interventions as you go. So when you think about your primary survey, you have airway, breathing, ventilation, and oxygenation kind of all going to be together, circulation, D, disability, and then E, exposure, and examine. And guess what? A good chunk of these, you've actually already been starting to work on with your pediatric assessment triangle. Now, exposure examine, you haven't gotten there yet, but you've definitely started your pediatric assessment triangle or your primary survey with your pediatric assessment triangle. Now you just have to kind of fill the gaps in. So how do we think about sick or not sick, and how do we approach these children after we've done our pediatric assessment triangle? So this is based off of sick or not sick teaching that is out of King County. And this is a protocol specific to us, but I would argue that in general, this works. You walk in and you say, the pediatric assessment triangle, we're A-okay. Appearance is good. Breathing is good. Circulation is good. It's a stubbed toe. But you walk in and you still should do your primary survey. You know that they're not sick based off their primary assessment triangle, but now you got to investigate the rest of it. It might be a stubbed toe, but it might be a stubbed toe with a lot of other injuries that you just haven't noticed yet. So walk in, do your primary survey, get your baseline vitals, then do your secondary survey, get your physical exam in, and do your history. Anytime while you are doing your primary survey, baseline vitals, your rapid medical survey, all of this, you find something that's abnormal that worries you, you can still flip into from sick, not sick to sick. You have done, again, your screening test, but it isn't perfect. So you still need to investigate and see if you're missing something from your primary assessment triangle. So your primary survey for the not sick kid, airway, breathing, ventilation, oxygenation, circulation. Again, get an LOC, take a look at the pupils, and really just intervene as indicated if you find something and you need it. Now, a quick side about vital signs. I am a huge fan of vital signs in pediatric patients, if you haven't noticed already. Now, blood pressures are hard to get in really tiny kids, and we're going to talk a little bit about kind of ways to circumnavigate that a little bit, because depending on what your equipment is, you may have trouble doing it. And you were asking about blood glucose. Oh, it's so in like 4 slides. Thank you so much for asking, Steve. So when you're thinking about vital signs in these patients, making sure again that you get a good heart rate, you get a good respiratory rate. Please get a pulse ox on all these children. I can't tell you how many kids I've been like, this kid looks totally fine. And then I'm like, oh, and their stats 85%. Oops, my bad. I was totally wrong there. And they just hide the hypoxia. So get a complete set of vitals, or as complete as you can, and compare them to, again, your standard hand teddy for Whatcom County. You're going to want to compare them to your normals. It's really easy to be like, this child is scared of me, and so their heart rate's really high. I would argue the opposite. A high heart rate is scary until you've proven that it's because of anxiety and not from something else. And so it should be taken seriously in that context. All right. And blood pressures. Blood pressures are delightful when you can get them. A nice rule of thumb is that the minimum systolic blood pressure in the youngest age child is 70. And then you can add a couple of points for how old they are. The normal blood pressure in a child is 90 plus. And if you ever see a systolic blood pressure less than 70, you have a big problem. I don't care how old the kid is, you have a big problem. So again, use your norms, but remember, 90 is the minimum normal at any age. 70 is the minimum normal compensated. And it moves up depending on how old they are. So a 4-year-old, 78 is their minimum systolic blood pressure for compensated shock. Again, use hand teddy, use your tables. Now, capillary refill time. What if you don't have equipment that can get you a blood pressure in a pediatric patient? This happens in the hospital sometimes too. Kids are wiggling around. Even with an automated cuff, you can't get it. In a little baby, when you are doing manual blood pressures and they're wiggling, they're moving, where do I listen for it? It can be really difficult. So look for capillary refill time instead. Capillary refill time, we will look peripherally and centrally. And generally speaking, I care most about what's called a peripheral capillary refill time. So you take a finger or you take a toe. You don't have to push the nail bed. You can if you want to, but you just push the tissue. Push the tissue in the finger, push the tissue in the nail bed. You look at Blanche and you let go. And you count 1, 1,000, 2, 1,000, 3, 1,000. And all of you, hopefully you're all healthy individuals right now. It should rebound in less than 2 seconds, and that's normal. If it's anything longer than 2 seconds, then that is a sign of shock until proven otherwise in these patients. And it's a nice surrogate if you don't have a blood pressure. All right, heart rate. If it's too fast to count, it's probably too fast. I don't care how old they are, but try listening with a stethoscope and counting that way. It's actually a little easier if you listen with a stethoscope and count than it is sometimes to feel a pulse, especially when it's going rapidly. For some reason, it's a little easier to often count it with auditory counting as opposed to tactile counting. So listen, if you're comfortable feeling, feel it, but get an accurate heart rate too. And then remember, poor skin signs and tachycardia, so poor cap refill and tachycardia, is shock until proven otherwise. So that is a sick child. And then we talked about respiratory rate a little bit and how important I think it is. One of the tricks is lift the kid's shirt, or if the kid's scared of you, have mom or dad lift their shirt and just count it based off of looking at them and looking at their chest rise and fall with their shirt up. It's also a really nice way to catch retractions underneath the shirt. The shirts hide retractions really well. In kids, I know it's a pain, count for 30 seconds, get an actual good respiratory rate, because again, if it's too high, it's a problem. And in general, don't try to do a respiratory rate and a whole bunch of other things at the same time. If you upset the child, you startle the child, or you cause them to cry, then you'll lose your respiratory rate. Similarly, I try to do heart rate the same way. I'll spend some time getting the child interested in my stethoscope, and then I'll listen to the child while I'm talking to them until I get them to settle, and then I will count their heart rate that way, as opposed to having them screaming and trying to just do it by a tactile, by just feeling for the pulse. All right, so your rapid exam. There's lots of ways to do this. I'm not going to teach you all how to examine kids because you're very, very smart people and know how to do it. I personally take the head to toe or the toe to head approach. So in a kid that looks like they don't like me, which happens a lot in the emergency department. We're kind of a scary place and we tend to have needles, so children don't like us. I will start from the toe and I'll go to the head. So I will start and I will literally play with kids. I will take my stethoscope, I will listen to their knee and ask them, is this the right place to listen? And they all laugh and think I'm an idiot, and that's totally fine. And then I'll listen to their thigh, I'll listen to their elbow, I'll kind of work my way up and get them comfortable with me. So I kind of do this distal to central approach. The head to toe exam takes a little more time to get report. It depends on the age of the child and if you can talk them through it. In an infant, a really young infant, they don't care where you start and where you end, so that doesn't matter so much. But in an older child, if you're going to do head to toe, just spend a little time talking to them about what you're doing. I definitely love using a toy, using parents. I'll examine the parent, then I'll examine the kid. But remember, this is sort of you want to get a good exam on these children. And so because of that, you want to spend some time with the exam and trying to get them comfortable as you walk through it. All right, sample history, we all know how to take it. I'm not going to belabor it, but make sure you do double check it because parents will tell you the darndest things. I do love it when families are like, oh yeah, so everything was totally fine, but oh yeah, she got grandma's pills. And I'm like, you totally forgot to mention that like 5 minutes ago and your child's acted weird. So do kind of walk through a little bit and try to extract a little more history out of parents if you can. So what happens if that was the not sick child? What happens if they're sick? It's not really different. You just do some things at the same time. So your pediatric assessment triangle, you're like, oh, this kid is sick, we have a problem. So start your primary survey. And if you don't have ALS already responding with you, request ALS or start working your transport towards a hospital where they have more advanced treatment modalities. Once your primary survey, you're working your way through, start treating it. So put some oxygen on the kid. Start kind of working your way through what else do we need to do. But again, get your vitals, do your rapid survey, get your sample history. So now for BLS, you actually have a lot you can do. You can reposition the airway. A lot of pediatric patients, especially after a febrile seizure, for example, they're snoring, they're maybe not oxygenating really well. You reposition them, you just give them a little jaw thrust, and now they're breathing brilliantly. I'm a huge fan of oral airways and nasopharyngeal airways in patients that will tolerate them if you need to help open their airway a little bit. Oxygen is never going to be wrong in the short term in a pediatric patient. And a bag valve mask, you can bag a kid. In fact, there are many patients that I will just use a BVM. I won't intubate them. I won't put an iGel in. I'll just use a BVM for 5 or 10 minutes in the ER. Now, granted, I have a lot of support around me, but I'm doing that because I'm like, I wonder if this kid's just going to get their act together and they don't actually need me to intubate them. It's entirely possible. So I'm just going to sit here and bag them a little bit, and they actually tolerate it really well. The vomiting that we're all afraid of in adults, it does happen in kids, but it's less of a problem. They do well with it. So don't be afraid to just support their ventilation a little bit. Bleeding control, sort of a duh statement again to our trauma. We do that for everyone. And glucose. Any child that is in any way sick, to exactly what Steve asked about earlier, you should check a glucose in. I in fact, tell people I would much rather you check the glucose than not. I don't care how the kid looked. The kid could be smiling and talking to you and something seemed off to you. You check a glucose, good job. Thanks for doing it. It is always, always, always reasonable to check a glucose. And then don't forget to examine and expose them. All right. So your primary survey, again, your pediatric assessment triangle informs your primary survey. And now your primary survey, you kind of is cyclic. You do the survey, you do the rest of your exam, maybe you intervene on something, and now you come back and do your primary survey again to see how they're doing. And then my personal fave is the DEFG. If I haven't made the point enough yet, please don't ever forget the glucose. Now, I'm going to tell you a fun story about me recently. I love to tell stories when I'm an inept ER doctor, and I'm not terribly inept, but occasionally I'm like, I could be better. So I took care of this adorable child the other day who came into the emergency department. She was febrile. I can't remember how old she was. I want to say she was like 7, somewhere around there. She comes into the ER. She has a bad fever, and mom is like, yeah, every time she gets a fever, she just kind of like a limp noodle. She doesn't want to do much. And so she's sitting there and she doesn't really want to talk to me, but she is looking at me and she's tracking me. But I'm like, but she won't sit up and she doesn't want to hold herself up. And all I can think is something's really wrong and I don't know what it is. And this doesn't seem right. And we're going to, start on IV and we're going to do a bunch of stuff. And then the tech, God bless the ER tech, checks the glucose. And it's like, hey, Dr. Wall, the glucose is 40. And I was like, oh, that would explain our problem right there. There we go. Hey. So I was like, well, that was not my best moment because I didn't think to ask for it. So the like EMT basic brain in me is just crying and dying inside, and I'm a little embarrassed, but learn from my story. Always check a glucose, because then we fixed it and she looked like a peach. So always, always, always check the glucose. There's no problem doing that. In general, for hypoglycemia in pediatric patients, we treat less than 60. Some protocols will use less than 50. Please use whatever your local protocol is. There's actually like some debate in the literature about whether we use 60 or 50. So again, use your local protocol. What I will tell you is oral glucose gel works great in kids. It is my favorite trick, especially when we're having trouble getting an IV in. It is completely reasonable to start taking a little oral glucose gel, put a little on your finger, and just rub it into the buccal mucosa. And you can just keep doing that. And you can actually bring the sugar up nicely in a pediatric patient while you are waiting for ALS intervention or you're transporting them to the hospital. It's also lovely when you're the EMT basic and the paramedics are having trouble getting the IV or the IO, and you fix the sugar with oral glucose gel, and then you just show what a rock star you are. So don't forget it. Always, always think to use it. It's totally fine in pediatric patients. All right. So you've done your pediatric assessment triangle because you're a rock star. You've done your primary survey. You've checked a glucose because you're amazing. Now, how do you know you're doing things right? So we check, and we recheck. You put a patient on oxygen. How does their mentation change? Does their color improve? How you give some patients some glucose. One, you should probably recheck the glucose, but two, how is their mentation? Whatever you are doing for your intervention, always be reassessing the patient to see if they're responding to your intervention. And then signs of improvement in the pediatric patient. So improved mental status. You want to reduce work of breathing. So you have a patient that's working really hard to breathe, but you put oxygen on them and they look a little better. Dude, that's a win. Good job. Improvement in the respiratory rate. Their respiratory rate was 60 and now it's 50. Also, good job. That is a win. Their skin color gets better. Capillary refill is improving. And then their tachycardia is improving too. These are all signs you're going the right direction. All right. So I've done a lot of talking. You've done a lot of listening. Thank you very much. Let's do some videos and see how you guys feel about some real life examples. And then I believe I shared this. Give me 1 second. I'm going to actually pause and reshare really quick because I want to make sure the audio comes through all the way. And I don't remember if I did that correctly the first time. So give me just one moment, guys. There we go. And we're going to optimize for video clips. I knew I forgot something when I was reminding you to record. Okay. All right. I'm going to play it again for you guys. So your pediatric assessment triangle. What's wrong in this kid? I'm going to play it again until someone answers. Breathing. Yeah, breathing. Thank you all. Yeah, so breathing. This kid, I would argue this kid's a little flushed in the cheek, but not pale, so probably okay overall. But yes, we have a breathing problem here. So this kid is by definition sick. The flushed and the pallor is a little hard to tell. I'm like, you could argue either one. Circulation in general looks pretty good, but this kid is breathing a little fast. They're retracting a little bit. And the kid's just sort of laying there like a wet noodle. They're not really sitting up. So there might be some mentation stuff in there. Breathing, definitely out. Circulation, probably okay. I'd argue the flush makes me think, but still we have a breathing problem. So by definition, sick. Now, when you get this kid and you get some vital signs, I'll do it one more time. Yeah, so the blood pressure is a problem. This kid is hypotensive, tachycardic, breathing really fast, has terrible cap refill. And I don't love that moaning sound in the background. It's not very robust. That right there is a nice example of delayed cat breath though. And grunting, yeah, I would actually argue that might be a little bit of a grunt. It's a good point. I don't love it because it's sort of a moaning sound, but it's at the end of every breath. So I'd be like, something in here I don't love. This kid basically is in shock. This kid now has taken out all parts of the triangle. The appearance, not great. Maybe that moaning could be a respiratory problem. It could be a mentation problem. Breathing sucks. Circulation sucks. This kid's in shock. This kid is really sick. All right. What do you think of this kid? Oops. I clicked too quickly. Yeah, breathing and appearance. I'm 100% with you. This kid's breathing is kind of weird. This kid is sick. Like this breathing pattern is odd. It's a little, he's not breathing really fast, and it's sort of kind of it's not fully regular. So this kid, 100% appearance out, breathing out. Circulation looks okay. But when you actually get this kid on a monitor, there's the kid's vitals. Who is terrified by those vitals? I personally would look at that and be like, oh my God, we have big problems here. It is almost CPR time, 100%. Said like a PALS instructor, yes. So this kid is super sick. This kid is cardiopulmonary failure. Yeah, this kid's heart rate sucks. Their pulse ox sucks. Their appearance is terrible, and their breathing is terrible. And so essentially you have circulation's out, breathing's out, and appearance is out. So this kid is sick, sick, sick. We have problems. All right. All right, what's out in that kid? Breathing. Yep. Anybody want to diagnose this by the sound?
Play it one more time.
What sound is that? Audible wheeze is a great guess. That is stridor. So this is why audible wheezing and stridor get overlapped a lot. In this kid, this is actually stridor. Stridor is an upper airway, and you got to hear it like 1,000 times to get it, but upper airway is very much stridor, and wheezing, lower airway, can sometimes they overlap in what they sound like. It's really easy to confuse them, but yeah, this is actually stridor. This kid has croup. So this is a breathing problem. This kid is sick, but his appearance is good. I mean, he's like sitting there like rubbing his eye and not looking like the world's ending, and his color's not bad. So he's sick, but he's not the end of the world sick. We just have some problems. Now we put him on a monitor. The rest of his vitals are actually not terrible. He's not super tachycardic. His sat, I never love a sat less than 100% in a child, but 96, 95 is not bad. His blood pressure is good. So he's sick, but he's respiratory distress, but he's not respiratory failure. Little oxygen, transport to the hospital, get some drugs there. He'll be fine. All right. Okay, so the sounds are hard to hear in this kid, but I will give you, there's like a little gurgly, little snoring in there. Breathing, yes, 100% with you. And I agree. I actually think appearance is off too. I mean, this kid is positioned and a little out of it. Now, granted, he might be sleeping. We might wake him up and he's fine, but I would err towards sick, more sick than less sick. So I would say appearance and breathing too. Totally agree. Oh, I didn't say that. Oh, geez, I didn't update my slide. All right, Adrian, I still agree with you. I'll fix that later. My bad. All right, so this kid is still sick. Now you put this kid on a monitor and you hear expiratory wheezing now that you listen to him. Skin tone isn't great either. Yeah, I know. There's all sorts of stuff that's off in this kid. It's a little tacky, not bad. 130s isn't terrible for this age. But I'm going to tell you, SATA 94 already on oxygen is where I'm like, huh, that's not normal. That's not great. There's a lung problem in here. So this is a kid that's sick. And you can pick up on that. You haven't even technically listened to this kid's chest. Besides, it tells you expiratory wheeze, sure, but this kid's sick. All right. All right, someone tell me all the things wrong with that child's breathing. I mean, I love the mask is in the mouth, but at least mom fixes it. Yeah. Yeah, this kid's breathing really fast and is retracting everywhere. Totally. And I agree with appearance actually too. I think, yes, Steve, you raised your hand.
I did. So I noticed in all these pictures and all the videos, and we all understand position of comfort, but wouldn't some of, especially this last one, wouldn't
This one?
it be better if yeah, this one right here, wouldn't it be better if he was sitting up more? Or I just, it's kind of interesting that
Yeah.
I know the video before the child was sleeping, but
Yeah.
I don't know, it just
Sleeping on mom.
so
Yeah.
uncomfortable, even the kid with the strider. I mean, just maybe sitting
Yep.
up a little bit might
Yeah.
have
The
been
one with
better. I don't know.
the one with the strider, I just want to sit that kid up. I'm like, you're so curled. I just want to sit you up. I agree with you. Some of this also, so there's a balance between position of comfort and a balance with work of breathing. And so the way I think about it is if a child is mentating well, like well enough that they can hold the position they want, I'm going to let them do it. If the child is altered and they're not able to hold, and then I'm going to put them in a position I think will do better. So it's the example is sort of that child when we talk about you've done your pediatric assessment triangle and you're doing your primary survey and they're snoring and they're gurgling and maybe they're curled up and maybe they just had a seizure. They're altered, you open their airway, you give them a little jaw thrust, and all of a sudden that gurgling and that snoring goes away. And that's because, to your point, that kid was positioned poorly and is altered enough to not hold a position. So that's a kid I 100% reposition. If a child like this kid here, it's a little hard to tell. I think his appearance, I agree with you, Jeff. I think he's probably not mentating brilliantly, though it's kind of hard to tell from the video. This is a kid that if he'll let me do it, would reposition to open his chest a little bit more. But if he's going to fight me on it, I also don't want to make it worse. So I would allow the position if he's mentating well. It's a balance. If they're good enough to mentating well enough to hold their own position of comfort, more power to them. If they're not mentating well, then I 100% will position them in the way I think is going to work best for their airway and their breathing. It's a really good point. So, and this kid to me, yeah, breathing looks terrible. His appearance isn't great. And all I can think is, oh, we need to open those lungs up quickly. This looks like really, really, really bad asthma. So you appropriately got, so this kid, appearance not good, breathing not good. So he is sick. All right. So we put him on a monitor. He is presumably on a neb with 100% oxygen, and his SAT is 91%. He's tachycardic, and his lungs sound like poop. So now our suspicion is confirmed. He is very sick. All right. So this kid's bordering towards respiratory failure since his mentation isn't there. So summary. You guys nailed it, by the way. Thank you very much for playing the game. So again, pediatric assessment triangle. That is, you are all really savvy pre-hospital providers. You look at dozens and dozens and dozens and dozens of patients in your career, and you look at mostly adults, but it's not that different in kids. Look at it, look at the child, see, hey, are they maintaining appropriately? Are they paying attention? Are they not? Are they tracking? Are they not? How does their breathing look? I mean, you can get a lot out of a kid by just having mom or dad lift a shirt and just look at their breathing from 10 feet away before you walk up and the kid freaks out. And then circulation, just look at their skin color, get a really good assessment before you even get up to the child and maybe cause some stranger danger. Just get a good assessment from the door. And then remember, primary survey, and just keep doing it. You intervene, you fix something, keep going through your primary survey. And don't ever forget a glucose, because it is my favorite lab ever. And clearly I forgot that the other day, and now we'll remember forever again. So, all right. Remember, check, check, and recheck. We went over this. So just intervene, check, and recheck, and just look for signs of improvement. Or, granted, I wanted to be positive, but also look for signs of decline. If you redo your primary survey or your pediatric assessment triangle and you're like, oh, this kid's looking way worse, that's also an indicator you're going the wrong direction. You need to kind of up your game and intervene more. So, all right. That is what I have for you all today on pediatric assessment. There's a QR code if you want to give me feedback, because I'm always looking to improve lectures. My email, my cell phone is on here. I'm always happy to get comments, questions, concerns, complaints, anything really, feel free. If there's any questions or anything anyone wants to chat about, I know we have some time, because I only had an hour lecture. Sorry, Steve. So.
No, that's perfect. Does anybody have any questions? Oh, there's a question. Oh,
Cool, thanks.
Thanks for the comment. That's great. It's to you, not to me, but that's great. Fantastic. I do have a question, especially checking the glucose on an infant. Is it still appropriate to go to the heel, or is it still in the finger? I mean,
yeah, you can do the finger or the heel. In a brand new baby, we'll often do it the heel. But after a couple of months, we'll usually just do it in the finger. Either is fine. You can also do it in the toe too. It brings up a very subtle side point, but for both BLS and ALS providers is when you do any procedure to a child, you check a glucose, you place an IV, really you splint something, documenting that you did it and where you did it and well is important, because if we end up trying to investigate where did these pokes come from on this child, what's been going on at home, it's really helpful if we know that EMS had to attempt to get a glucose twice in the heel, and then we're like, okay, well now this makes sense. Now we're not thinking, someone has been doing something harmful to the child at home. So, but it's completely fine to do it in a finger, a toe, or the heel. All are very reasonable.
Well, keeping in our time frame. There's a question out there.
Thoughts on POV transport to the ER urgent care for suspected RSV or croup? Oh, Adrian, way to open a fabulous can of worms. All right. Depends on how the kid looks. And it depends. I mean, okay, so I'm going to soapbox this a little bit, but I'm going to preface this soapbox with you 100% need to follow your protocols and your medical director, because I am neither of those. Cool. I think if you are able to get really good vitals on a patient, so you have a patient with RSV, so bronchiolitis, and you're like, oh, okay, well, they're breathing a little fast, but they have a normal oxygen saturation. They're not working hard to breathe. I would actually argue that kid needs to have a normal glucose, because they can get dehydrated and can get not have good intake while they're sick. And you're like, this kid's setting 100%. They're not working that hard. I think we're good. And you want to send that POV to the hospital. I'm okay with it as long as you know that kid's going to make it to the hospital or the urgent care. We've had a handful of cases, and I do a lot of QI review. There've been a handful of cases where kids have been sort of prematurely cleared to go to the urgent care, and they show up with a glucose of 10. And they're like, oh, well, the kid was just tired. And then it's kind of like me getting like totally missing the fact that this kid had a glucose of 40. And it was just sort of, it was, I don't want to say written off, that's the wrong word, but it was interpreted as, oh, the kid's had a fever for a couple of days and they're just tired. And so I think it is reasonable to send a child POV, but you should have a fairly kind of low threshold to transport, just because Kids are really good at hiding illness. Again, that pediatric assessment triangle will get you 80% of the time, but 20% of the time, the kid's going to hide their illness and could actually be quite sick. And so if the kid looks like an absolute peach, you've done a really good assessment, you've documented complete vitals, and none of them are abnormal, I think it's reasonable to do that and to send them to the urgent care, the ER POV. But again, follow your local protocols. So, and for croup, I got to tell you, if they're having the barky cough here or there and don't look bad, sure, I guess that's reasonable. But if they have any stridor while they're talking or at rest, that's a kid that probably actually should go via transport, because if they progress, they might need some oxygen en route. So take it with a grain of salt, though. I look at all the bad cases. So.
And when you transport, well, of course, we can't transport to urgent cares at this point, but in my other jobs and other places where you could transport, where you let the patient go by POV, they get to the urgent care. What's the first thing the urgent care does? They call 911 and you
Mine freaks out, yeah.
Right?
Yeah. And to the urgent care point, I think you also really need to know your urgent care resources in the area, because at least in King, so I know the counties I work in, right? So I know King County best, I know Snow County somewhat, and there are pediatric specific urgent cares in our county that are comfortable with kids, but a lot of the other urgent cares in our county are staffed by internal medicine doctors that don't do kids. So if a child shows up with really anything, they'll flip out and send them to the ER anyway. So in general, you really need to know those resources well if you're going to consider an urgent care. So.
Well, Jesse, thank you very much for spending this time with our EMTs out here in Whatcom County. It's very, very much appreciated. It's great. I learned so many different things now, because pediatrics have always, we have been using hand tapping and did a lot of pediatric patients and everything else, but well, I learned so many things. And so thank you very much. Unless there's any other questions, we're going to say thank you very much, and we'll talk to you soon.
Thank you all very much for being here and for all that you do. I really appreciate it.
Thank you. Bye.
Steve, do you need anything else from me? I'll send you the PowerPoint when we're done. So.
Okay, that's fine. No, it went well. I was I was waiting to answer questions. I wanted to see if anybody else was gonna do that.
You got good. There's good involvement. People
Yeah.
participated. Thank them all. So
Yeah.